I am so excited about tonight. This is such a big deal. Just to warn you, I might disappear because BeLive is being a little bit funny so that we can get Kristen Kirkby-Shaw to come and join us. So if I disappear, I'll pop in, I'll pop out. But really, tonight is all about these guys, and they've given up us their time to really go into detail about something that's really important that you, the public, probably don't understand yet. By the end of the night, you will. So tonight we're going to talk about evidence-based. Don't switch off. Don't disappear. Don't put your iPad down, because this is important, because it's going to make sure your dog gets the best treatment that we know is safe, is effective. It's also going to save you money, okay? So just because we're not talking about a specific drug or a specific supplement or a specific food, don't leave, because by the end of tonight, I'm hoping that you guys will really, really understand what the veterinary profession is now trying to do with regards to evidence-based medicine. So I'm going to let these guys introduce themselves. And as I say, if Kristin joins us, because I know she's probably still in surgery, I'll disappear and these guys are going to take the lead. All right. So Karen, start with you. Please tell the followers who you are, what you do.
Hey everybody, I'm Karen Perry. I did all of my education in the UK at Edinburgh University, both undergrad and residency, and then worked at the Royal Veterinary College for 4 years before moving across the Atlantic to work at Michigan State University, where I've been for nearly 6 years now. So I'm one of the orthopaedic surgeons there, very clinically based. I spend most of my time on clinics, do some research and teaching responsibilities as well.
And David?
Thank you. So I'm David Dycus. I am in private practice in the United States. I practice in Maryland with a focus predominantly in orthopedics. All of my training was in the United States, and within private practice, I see a large caseload of not only companions, but also canine athletes that fall into very sporting dogs, as well as working dogs, military, police, that sort of thing. A lot of my background from a research standpoint, when I was a resident in my graduate studies, was in the area of osteoarthritis.
So, just to take you a little bit of history here. Back in 2015, I felt quite alone with this sudden passion of OA. And over the last 5 years, I've met the most amazing people that are as passionate about this disease as I am. And these two corkers. So stay tuned. So what we're going to do tonight is talk about evidence-based and why it's really important. And where has this come from? So we have this lovely community group called Holly. And what the ethos where we discuss things and we try and make sure people have foundational treatment plans, because it's very easy for an owner to jump to drugs and jump to supplements, and they haven't got the weight off, or they haven't done the lifestyle change, or they haven't even got a diagnosis yet. So Holly was created to make sure people get the foundations, but also to make sure it's a really supportive, empathetic network, so you don't feel alone. So a lot of owners, they might have children and a husband, but that dog is their dog, and they're watching their dog struggle, and they feel alone in their decision making. So we've created a community for you. Within this community, there's all saying, well, I've heard about this, and I've heard about that, and I saw an advert for this, and it was in the magazine. Why do they not buy into this? Is it because they don't have enough money out of it? Is it because their margins aren't enough? Is there some reason that vets would rather sell their more expensive product? And it really frustrates me, because I'd like to say that I'm a pretty standard, good first opinion vet, and money doesn't come into the way that I manage my cases. It's very much making sure what works for that dog is safe and effective. So it's for all of those people that think that vets just keep saying no about marketed things that are here, there and everywhere. I want you to understand why we say no, that's not likely to work. So Karen, can I let you kind of take the lead? Where did evidence-based come from? Because it's quite new, really, isn't it? And where is it going?
Yeah, I mean, I think evidence-based is maybe not 100% new. It's something that we've kind of termed more, and we talk about it more than we used to. So I think it's we've always kind of tried to use products in preference that we have proof that they definitively work. However, that term evidence-based medicine has become one of those kind of terms that's become more frequently used in our vocabulary and in the vocabulary just generally online as well, in the more recent past. So I think it's something we've always tried to stick to, that we've always tried to use products that have evidence before going down the products that don't. And if we look back, that's kind of, if you think of just like the drug cascade that we like, you know, in the UK, you have to use this certain drug before you use a drug that hasn't got evidence behind it. So just that cascade that was always in place is evidence-based medicine at work. It just wasn't really termed that at the time. It was more, everyone said, follow this rule, but they never explained this is why we're following this rule maybe. And now we're trying to be a bit more explicit about what we're doing and why we're doing it. But sometimes that terminology can still become super confusing for people, I think.
Yeah. What do you think, David? You know,
I largely agree. You know, the aspect of evidence-based medicine, at least on our end of things, allows us to make the best informed decisions, knowing that what we're going to recommend or offer is going to have the best chance of working. And it also helps guide management strategies. It allows us, if we want to talk about finances, it allows us to recommend things where we're going to get the most bang for our buck, rather than recommending random things that, you know, we may spend money on and it may not work, and vice versa. And so, you know, the evidence-based medicine standpoint is really helpful as our knowledge base of osteoarthritis continues to evolve, because even though it's a topic that's very well researched, there's so much that we don't know. And it's very evident not only on the veterinary side, but the human side. And so, you know, trying to make these recommendations, the evidence-based medicine standpoint allows us to provide best recommendations for us to provide quality care.
So for people that don't really know what we're talking about, what does evidence-based consist of? You know, be a kind of bit more descriptive, you know, clinical trials, blah, 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 blah.
You start, David.
You know, I think, you know, there's certainly some differences between the human world and the veterinary world that we have to look to. And, you know, in the human world, when they make recommendations on a specific supplement or a specific drug or a specific rehab modality or a specific injection, they're going to have gone through various clinical trials. And it usually is going to start somewhat of a benchtop research with very basic science. And then it's going to enter into a clinical trial with patients with a small number. And then it's going to grow because what they have to first make sure of is that the concept works. Then we need to make sure that what we're recommending is safe. And then once we know if it's safe, we can start looking at the efficacy. And as you draw more people into a study, you might start to appreciate certain side effects that you weren't anticipating, or that it's not as effective as you thought it might be. So studies in people may incorporate initially hundreds and then to many thousands. In veterinary medicine, we're lucky if we get a study with 100 dogs in it. You know, most of our studies are not heavily powered. And so we have to really gauge that data, look at that data and see, you know, how helpful trying to extract that it may be for our patients to make recommendations, or should we start to change our mindset on how we recommend something?
Yeah. Can you add anything to that, Karen? Guys, by the way, I keep looking down because I've got the list to get through, so don't think I'm rude. I'm just like, whoo, we got a lot to do tonight.
No, I think something that David brought up there that is super important is that kind of staged fashion with how it goes, and like that we get data on the fact that it's kind of safe before we get data on the fact that it actually works. And a lot of the time you'll see things starting to drift into the market when all we know at this point is that they're safe. We know they don't kill things. We know they don't have horrible side effects, but we still don't know they actually work. And there's quite a few things that make it onto the market before we have that efficacy data. So sometimes if you don't read all of the studies very carefully, you can kind of say, well, you know, maybe I should be using this medication because it's new and it's out and it says it's for OA and there are studies on it. But you really have to read the study and say, well, what does this study really say? And it says that it's, you know, it doesn't kill things. And we know that the drug reaches this level at this time after we give it, but we still don't know if it actually works for most patients or any patients at that point. So kind of reading, really keeping on top of the data is super important so that we can make the best recommendations. And sometimes we have to say, well, I might need to go and do a little bit of research on that, because last time I looked at this paper wasn't out yet, but let me go check. Maybe it's changed. And it changes daily, what the evidence that we have, especially in fields like OA, where research is ongoing all the time. So
and I think people probably don't appreciate how long data takes to collect, you know. So one of the best kind of studies is like a prospective, lifelong study. So we're talking watching a dog and its response to an intervention for years. So, you know, things take a long time to collect, and lots and lots of hoops to jump through to make sure that that isn't biased data. So these trials that people create are really fine-tuned to make sure that they don't give us the wrong impression. But then there's also the data that's very retrospective and looking at things that we've done in years gone past and collecting data. So every time we try and create an impression of whether something is effective, there's a lot of legwork to get there, isn't there?
I mean, there is. I mean, it starts off at such a different level as well. Like David said, you start off on the bench top, and like, you know, you're going to spend probably a couple of years at least doing that bench top research to get the answer. You know, does this have legs? Is it even worth taking any further in terms of putting it in things? And then the next stage might be nothing to do with dogs. It might be you put this in laboratory rats next and see what the rats do. And then just because rats do it doesn't mean dogs are going to do it. So then you have to take it into the dog study, and all this takes years and years, which is why we hear about these promising new therapies, which are very, very promising in terms of we know the pharmacology works, and we know that there are receptors that this drug should work on, but we don't know that it works in a dog or even a rat yet, let alone anything else.
Just I'm having a little bit of a giggle, because do you remember Zubrin?
Oh yeah.
Yes.
Do you remember why it didn't actually kind of go anywhere? Because the tablet that was supposed to be sticky and it stuck to the tongue actually stuck to the person's finger. And they couldn't get it in the dog. And so this company had gone through years and years of data collection and trials, and then that simple thing of it doesn't come off the finger and go on their tongue. Anyway, that's a tangent. I always try and keep it lighthearted.
You know, and I think the other thing that's important to take into consideration is not all research is created equal. You know, when we talk about this evidence-based medicine, and so, you know, somebody says, well, here, this paper was published. And we have to be very cautious when we look at studies, because there are biased papers all over that are published on a daily basis that are really trying to push a product. And so, you know, what we really have to do is at the beginning of the day, all of us are scientists by nature. And so we have to put on our scientist cap and really look at the study, evaluate the data, and say, you know, does this actually make sense? Was this a well-designed study, or was this flawed from the get-go to already kind of get these results they're publishing to try to get this product on the market? And so, you know, veterinarians should be reading the journals, but they should be really scrutinizing the journals. They should be scrutinizing the data to make sure that just because it's there doesn't necessarily always mean it's good, and you know, not having good quality research can certainly affect our ability to rely on evidence-based medicine to make recommendations.
Yeah, and just in defense of people like me, because I am a mere lowly person, you know, clinically scrutinizing papers is a gift. It's a skill. It takes quite a lot of training to be able to break a paper down, and I have not got it, and I would love to have it, and I will learn it before I'm 50. But it's very easy to be kind of blindsided by paper. You know, you look at it, you go, wow, that's amazing. The abstract sounds immense, and you're really busy at work, so you go abstract, you go straight results discussion, and you actually miss the method and the whole structure of the trial. You kind of just leave that out. I haven't got much time. So we do rely on people to actually bring data together, don't we, and kind of summarize it, and also look at many papers and bring them into a collective opinion. Just tell us how they do kind of evidence-based approach to surgery, because that's different. That's really quite a different understanding compared to using just a product, say a drug or a supplement or a food. What kind of way do you guys look at whether your surgeries are the right one, for example?
Yeah, I think a lot of the procedures that we utilize have been looked at for a number of years. Not only clinically, but a lot of times starting with what's called an in vitro study, where we try to mimic what would be going on in real life, sometimes with cadavers. We say, this may work. And then again, it goes through that process of being applied to a select number of clinical patients. And sometimes it fails miserably, and then sometimes it does great. And the kind of procedures that we do, at least orthopedically, a lot of these procedures have been around for a number of years, and we have a lot of data to support the outcomes, whether it's prospective studies, which we don't have as many as we would like. A lot of them are retrospective studies. But, for me, I'm not going to jump on the bandwagon to just start doing a new procedure unless there's good data behind it. It's been utilized in a number of clinical patients with successful outcomes. I don't want to take my patients and subject them to, let's do the trial and error and put them at risk. I need to make sure that what I'm going to do is safe for them before I can recommend it.
Yeah, definitely. So evidence-based does come into a lot of what we advise. Just a funny another tangent, because that's here, I'm the comedy partner in the whole thing, is somebody once said to me, you can't really advise a dog about slippery floors because we've got no evidence that it can cause harm. And I'm like,
it's sort of like the old saying, like, how many prospective studies do we need to prove that a parachute is helpful, right? Like, yes. You don't need to have some jump out of a plane with a placebo where they don't really have a parachute to prove that the parachute's helpful, right? Like, some things you have to say, we don't have evidence based on, but like a slippery floor, it's kind of common sense.
Yeah, exactly.
Stuff.
I didn't know what to say to that person. I was just like, I'm just not going to talk to you.
Tell them to get their bathroom floor really wet and then try to walk on it really quickly barefoot. And then it hurts. And they conducted their own research.
And I feel that I'm stealing the lovely Kristen Kirkby-Shaw's phrase here, so I hope she does come to join us. But she often says there's evidence-based logic as well, and we do need to bear that in mind. So there are some things, let's just not go crazy on this. Okay, so let's go on. We're moving on. What do you do when good quality evidence doesn't exist? See, we're jumping. No, let's do that. Okay, so in work with vets, there is a real lack of good quality evidence because our case studies are quite small. You mentioned that a lot of veterinary studies, there might be 20 dogs. A lot of the work that's coming out about CBD, they're very small case studies. Mm-hmm. And that's kind of like neglected when you bump from the abstract straight into the discussion. You're like, oh, what? There was only 20 dogs?
I think there's more dogs that receive CBD across the world than have actually even been in the studies for CBD.
I know. There is a definite paucity of data there. But what do we do as veterinary professionals when there isn't strong data?
I think that for me depends a lot whether we're talking about what exactly we're talking about there. So if we're talking about, for example, a nutraceutical, so something that we know has been used for a very long time, that we know is very unlikely to cause any harm to anyone or any patient, but just maybe what we're doubtful about is, does it cause any benefit?
Yeah.
And if we're in that kind of situation, then I think I'm very open to owners, and I kind of give them all the evidence base that we have. So this is what we have evidence for: non-steroidal anti-inflammatories, the adjunctive analgesics. Not really. We don't really have a lot of evidence for those, but we use a lot of them. Physical rehabilitation, not a lot of evidence, but what we do have looks pretty promising, and we do have very good kind of basis from the human side to follow through on there. And then you get to things like nutraceuticals, where you say, well, we have really no evidence in the veterinary medicine literature that they do a substantial, have a substantial beneficial effect. There's also no evidence in the human field, where they've done much bigger studies than we have, that there's anything that has a huge beneficial effect. So I would just say that what I feel my job is to say, these are all the things we have evidence find. These are the ones we don't, but that probably don't cause any harm. And these are the ones that we don't, and they could potentially cause harm based on the information that we have. And then let the owners make an informed decision. How much money do they want to spend? But I try and say, well, I would spend my money where the evidence is. Then if you have money left over and you want to spend more, then spend it in the area where we've got no evidence it works, but it's not going to do any harm. And then if you've got still more money and you kind of want to risk it, then you can go down the other route and try those kind of, I don't know, Chinese herbal things that we don't even know what's in them. So that's kind of what I feel my job is, but that's very easy for me to say. I have 45 minutes to talk to a client and I've got time to have that conversation. Most of the time, I think, I'm not sure how you get that into a 10 or 15 minute consultation, to be honest. I think that's really rough.
Yeah. Can you add anything to that, David? Like, so if you have a situation where you don't have strong evidence about your next approach, what kind of things do you think, what's your barriers, what do you step over hurdles to make sure that you choose the right decision?
Yeah, I think Karen hit the nail on the head. A lot of it is, number one, okay, if what we're giving is safe but no evidence. Number two, is it not safe or we don't know no evidence, and then do we have good evidence? And many times what I try to explain to owners is if we have evidence of something, this is what we really need to recommend. And sometimes they're all on board. Like, every owner looks online about Nsaids and they get this picture painted in their brain that their dog's going to drop dead when we put them on an Nsaid. But time and time again, study again, Nsaids show improvement in dogs with joint pain. Now, what I'm not saying is that every dog needs to be on an Nsaid for the rest of its life, but a lot of times people get scared about that, even though we know that when they're used appropriately, they're safe and they're effective. When it comes to nutraceuticals and some of these others where we know, okay, it's likely safe, but the evidence is lacking, then we'll say, this is what we know, this is what we don't know. What I don't want you to do is take the finances that you have to spend on your dog, spend it on something that's safe but not effective, and neglect using what we know is safe and effective. If something that is, I have no idea what it is, if the packaging is in another language and I don't know what it is, I may say, well, let me reach out to somebody who maybe practices Eastern medicine and they can tell me, is this relatively safe, especially if they're on other medications? And then again, we kind of get in that same boat, but if I don't know what it is, I'm going to say, I can't consciously make a recommendation for you to use this because you could be causing harm to your dog. I don't know. I would rather steer you in this direction. And I think it's all about client education because they're the ones that get to make the decision. And like Karen said, my appointment slots are, usually about 90 minutes. And so I've got all the time in the world to have a discussion with the owner. But the first opinion veterinarian, I don't know how you guys do it, how you're able to get in skin, ears, teeth, vaccine. Yeah. Blood work. Yeah. Oh, let's talk about OA.
We're amazing.
and then there's 15 minutes in an appointment. It blows my mind.
We have X-ray eyes. We have 4 sets of hands. We have our mouth in the back of our head.
Yeah. And you guys don't go to the bathroom all day, and you don't eat lunch.
No, we've got bladders that are amazing.
you make us all.
No, it is true. So putting you on the spot, one each. We're going to keep it OA related. What would be the first thing you'd say for OA evidence-based approach, just a generalist approach? Pick one each.
But what's the one we've got the most evidence behind? Is that what you're saying?
Yeah, something that you would say with strong evidence. Go, yeah, we know.
You'll have anti-inflammatories.
Okay, and David?
Well, I would have to agree. Anti-inflammatories. Once we get below that, the curve goes.
Yeah. Quickly. I'm gonna steal weight loss.
Yeah. Well,
I'm the freebie girl.
You bring up a good point.
Yeah.
Weight loss is great, but if we're talking about science, evidence based, we know in people that weight loss has a profound effect. Yeah. But again, it's kind of like that common sense. There's not a big study out there that shows weight loss in the dog improves pain and discomfort associated with joint pain.
No.
So, so you got to go to that line of being like, we know that a thin dog is going to be a more comfortable dog. They're going to load the joint less biomechanically than a fat dog. We don't need a prospective study to do that. Although there is evidence. I mean, there's some lifetime studies. that have looked at dogs with hip dysplasia and groups that were restricted fed versus allowed to eat ad lib, and the group that was allowed to eat ad lib sort of developed radiographic signs earlier and had the need for pharmaceutical management earlier. So yeah, there is some logic to that.
But it's still a small study. I think it was 40 dogs. It wasn't large. Let's
It
be
wasn't.
honest. No.
This was
You
early.
You always
2000s.
feel like you're being a massive hypocrite, and you go, "This amazing study," and it goes, "For dogs."
Yeah. You can't. It's hard to use some of those terminologies on the veterinary side when you're talking about this landmark study, and it's like, well, but he had 12 dogs, so.
Yeah. No, absolutely. Okay, so let's move on.
And Kristen says she's trying to get on now, by the way.
Oh, perfect. That means that I might have to leave you three in control of Cam. Hey, Kristin. Right. Okay, you three behave, because I'm going to disappear. And I am going to keep posing you questions. I'll put it in the box outside. And then I just want you to have fun, okay? Because that's what Cam's about. We're lighthearted. We want people to feel comfortable listening to us. We don't want to be white coat and serious. So if any of you misbehave, I'll jump in and delete you, okay? So I'm going to... Let me see if I can make this happen. So, come on, Hannah. Laptop's not being very sensible. Let's see if we can... I might have to get rid of Karen for a bit. 2 seconds. Let's just hide you. Let's hide me.
Looks like she gave me complete control.
Can you hear me?
I can hear you. Can you hear me?
Okay. Yes. Wait, so Hannah's not going to be on? We're just chatting without her?
Hello.
Yeah, now we can talk about her because she's not on. So do you want to introduce yourself, Kristen?
Sure. Am I late?
Half an hour.
30 minutes. It's fine.
Half an hour late? Really? Oh my God, I'm so sorry. I'm really, really, really sorry there. So, but it's not, is it live yet?
Yep, you're live.
Yeah, you're live.
It is. Oh my gosh, I'm so sorry, world. I'm so sorry. Okay, I thought I had it all right. So I'm Kristen Kirkpista. I'm a surgeon and rehab specialist in Seattle, Washington, and obviously I couldn't get my time zone straight. So I'm really sorry for everyone out there, and I'm so sorry, Hannah. I thought I had it straight. It's a pleasure to be here and be included, and hopefully you can see me blushing through the screen here.
So we were, talking about evidence-based medicine, also some of the common sense logic aspect of things in terms of recommendations for OA. And before you popped on, Hannah asked us the question, if you had to pick one thing in the area of OA, what that you would recommend to clients with the most evidence base, what would it be?
Oh, for me, it would be weight loss, weight management, without a doubt. Yeah. Did you guys already chat about that?
Well, we were just chatting about it. I think we have a consensus between anti-inflammatories and weight loss would probably be the top two. And then I don't know about you guys, but then it kind of sharply dips for evidence thereafter.
Yeah, absolutely. I would totally agree. I think after that, in terms of the conversations I have, would probably be Adequan. If we're looking at any sort of supplements or omega-3s, but even then, compared to anti-inflammatories, of course, they're without a doubt going to be the most evidence-based out there.
That's it. That's interesting, because I guess if you look at it, I'm obviously more of a surgeon's perspective. I was going to say, if my next one about how much evidence do we have behind things, mine was a huge jump from non-steroidals probably down to joint replacement. So it's just like, that's where
absolutely, yeah.
Yeah, I mean, as a surgeon as well, a joint replacement's great. I think from a hip standpoint, we've got those down pretty well. Knees, elbows, ankles,
not so much.
Yeah, we got a lot of work to do. My hope would be, and kind of what I tell clients is that, think of the joint like an organ, and we're trying to prevent organ failure, because organ failure is going to be a joint replacement. And so Adequan is an interesting one, and I think you guys would agree that it comes down to early identification of OA for some of those. And then let's see. Can you guys see the comments about the question about expense?
Expense behind clinical trials.
Well, yeah, the expense. The age-old statement that it's expensive, so some interventions don't have it, not because. Okay, so I guess the question that Hannah's asking is on cost of clinical trials. How much money is invested in some of these things to produce evidence for efficacy of a product?
Yeah, people use it as an excuse. I mean, I think from my perspective, I think we're just starting a clinical trial into a new OA medication potentially. And I mean, it is hugely expensive. We've just put in a grant for 60,000 just to get the first kind of 30 cases through. So if you look at the amount of follow-up you have to do and the testing before you even subject the dog to that trial to make sure it's safe for them. And we're jumping in at the canine stage. All the work in the rats and the benchtop stuff is done before we even get to this. So it is hugely expensive. And I don't think it's an excuse not to do it or an excuse to try and run away without it. But I think it is a very valid concern that unless someone's funding your research and, then you really do struggle. You can't really do this just off your own back. This has to be funded research. And that means someone has to be prepared to fund it. And it has to be a large amount of money if you're going to get a large number of dogs. And as we've mentioned, that's probably the reason why a lot of the studies we have only have 30 or 40 dogs at a maximum, because it just gets too expensive to do it anymore. And the money that the companies make out of veterinary medicine just isn't sufficient to justify them getting involved much further than that, I would say.
Yeah, I worked on a clinical study looking at pulse electromagnetic field therapy. And just the pilot study for the 15 dogs was about $25,000, and then when we ran the power of analysis to figure out how many dogs we needed to get a statistical significance, it was something like 90 dogs, and the study was going to be $120,000 or something. And at that point, there's somebody's like, yes, I've got a tree in my backyard full of $100 bills, and we want to see this through, or they say, oh, that's kind of expensive. Is it really going to change what we do, just type standpoint? Because you got to also look at who's funding the study, right? Like, and the results of the study, if the company's funding it and they want it to be a positive, because then they want to be able to sell their product, right? And so sometimes it doesn't work out that way.
Right. And I think that's a huge problem, is that, I mean, when you have to be careful. Like the study that we're doing is going to be funded by internal grants of MSU. So that's the good news, is that then we get the say so as to whether these results get published or not. But it's a huge problem if you have, we have basically studies that are funded by that company. And normally what they'll write into your contract before you even start the study is, well, if we don't like the results, you don't publish them. And so those studies are rather ethically confusing to be involved with as a veterinarian, because then you have the data, but you're not allowed to do anything with it. So you have to be careful about studies that are funded by a certain company. And after one experience, I've really, and the experience of my mentor, I've kind of stopped there and just gone for external funding. But
well, and Hannah was asking a great question of, Kristen, you got something?
No, I was leaving us there. Go.
No, Hannah was just asking, so if we don't have systemic good evidence, like the very top of the pyramid, what kind of studies or evidence base falls below the pyramid that we can still use? Maybe it's not the best evidence, but it's still evidence. Like how does, maybe retrospective studies versus an opinion article versus somebody's Facebook page post?
Mm-hmm. You want to go, Kristin?
Sure. I guess I would say a lot of what I base some decisions on would be translational studies, and by translational meaning from humans to dogs and cats. And then what I think is more commonly thought of as translational is going to be the rat or mouse model, kind of rodent model being translated to larger animals. And then sometimes, whether it's pulse electromagnetic field or some of the other modalities that really don't have much evidence at all in veterinary patients, even just looking at the basic science of, well, how is this meant to work? And that's low level evidence, but sometimes that's all we have to go on, is what is the kind of theoretical nature of why this would work, and then, you know, go on from there. And actually, that actually just made me remember one of the other things that I think has more evidence than anybody ever remembers is ice, just in terms of cryotherapy for OA. Like, nobody's going to fund a study on ice packing, right? But there is, you know, pretty decent evidence in even dogs showing that it's effective as an anti-inflammatory and pain reliever.
Yeah. Interesting.
My goodness, there's a really long one that's just come through from Esme. There were a few client questions. I don't know if we want to go back and have a look at some of those as well, maybe from an evidence-based perspective. So Lynn was asking, are there studies that compare different Nsaids and their efficacy rather than focus on the efficacy or safety of just one drug versus a placebo? David, do you want to have a go at that one?
So there's been a few. Most studies compare to an NSAID, you know, what they're trying to reach. You know, what I've sort of gathered reading through a lot of the studies and kind of formulating my own thoughts is, you know, most of the NSAIDs that we use in veterinary medicine are all effective. You know, they all reach some level of efficacy. I think some dogs respond better to some versus others. But what I wouldn't say is that there's just one NSAID that is so much better than the other. I think they're all relatively equivalent. You know, I think most all of the NSAIDs that are manufactured by different manufacturers all sort of have their little niche, and they're not really looking to compete with each other. So, you know, I don't think that we're going to see like a study come out that's comparing, say, carprofen from Deramax and Previcox and Metacam and Galliprant and these others. Really what they look at is how effective it is percentage-wise based on the studies that have been done. So when Galliprant hit the market, I don't know if Galliprant's available in the UK or not, but you know,
it is now.
It is. Okay. So the dogs that showed improvement is relatively the same percentage of when the carprofen studies were done. So we can say it's as effective as carprofen.
Yeah, you know, Dr. Millis did a study a number of years ago that I remember seeing as part of the Deramax or Daracoxib marketing material from Novartis at the time, but it was a force plate study where he had dogs that had arthritis all walk across the force plate. So looking at, you know, we consider the gold standard in terms of evidence, and each dog was on a different non-steroidal and then had a washout period and then walked across the force plate again. And all of the dogs responded to at least one of the non-steroidals, but not all of them responded to the same one. So just to David's point that there's not necessarily one clear winner across the board. It's going to be different for each dog, but every single dog did respond to at least one of them. So that was important to see.
Right. And I think that's super interesting. And sometimes something that owners struggle with a little bit is that, you know, their dog might not respond to one, but may respond to another one. Sometimes I find they're a little reluctant to try another one after one hasn't worked, or where they've had side effects on one of them. And something I often kind of say to them is, well, if you asked you and all your friends what medication you take if you have a headache, like it would be different for every one of you, because you've decided that this works for you and doesn't make your head feel fuzzy and doesn't give you side effects or whatever. So I think sometimes just giving them, you know, something that they can relate to a little bit more, that makes them realize actually, no, it is okay to try more than one, and they've certainly done it in their lives. So it works on the human side as well. Going back, there's oh, here we go. There's the next one's just come up on the screen for us. So from Barbara, I'm giving my dog glucosamine, MSM, and chondroitin, reducing anti-inflammatories. I've heard some worrying news about them. What are your thoughts?
Well, I'll just give you my rundown. It kind of goes with what we were talking about earlier when we were talking about, you know, we got safety, evidence, and efficacy. We've got safety and no efficacy, and we don't know if it's safe or efficacious. So, you know, the way I look at it from an OA perspective is that we're going to have dogs that are going to be more painful than other dogs with OA. And what I mean by that is some dogs are going to be in a flare-up of OA where they have this inflammatory response and they hurt. We're going to have dogs that have OA, but they're not in a massive inflammatory response and they don't hurt as bad. The dogs in a flare-up, I think, are going to benefit from an anti-inflammatory. The goal is to get the flare-up under control, so to use the NSAID at the lowest dose possible as infrequently as possible, knowing that at some point with disease progression, we're probably going to have to use it daily. So the question then becomes, well, if your dog's on an anti-inflammatory, if we're in a state of pain and discomfort, we probably need to use the anti-inflammatory at the prescribed dosage to get that under control. Once that gets under control, maybe we do try to back off the dosage or try to stop it altogether. And sometimes it's a little trial or error. And then, again, I think when it comes down to the glucosamine, the MSM, and the chondroitin, we know there's safety there, and the efficacy is somewhat questionable. So, if you have the ability to give it, I don't think you're going to hurt anything. The big question is I would not phase out the anti-inflammatory for fear of the anti-inflammatory causing a problem if it's being used at the appropriate dose for the appropriate duration.
Right. I would completely agree with that. I think going, like, obviously evidence-based, we talk about evidence-based, efficacy, evidence-based. I mean, the evidence-based behind, in terms of what the risk of serious side effects from non-steroidals are, as David kind of alluded to earlier, is really tends to indicate that risk of side effects is very low. And the risk of side effects when they're going to happen tends to be when the dog first starts the anti-inflammatory. If the vast majority of dogs that are going to develop vomiting or diarrhea on an anti-inflammatory will develop it immediately they start the anti-inflammatory. So if that hasn't happened, then it's unlikely that vomiting and diarrhea is going to be a major problem. And that's the biggest complication we see with non-steroidals, which varies somewhere between 6 and 8%-ish, depending on which one we're talking about. So again, very similar across the board, and no reason to choose one over another, really, with maybe the exception of Galliprant, but we don't really have long enough outlook on that to say that it's substantially different, to be honest. In terms of the longer term side effects that people are concerned about, we often cite liver damage, kidney damage, and I think the big concern for that is that we kind of say we want to monitor your dog when they come in, and we say, well, every year or every 18 months, we just want to get a urine test, maybe a blood test if there's anything wrong, to make sure that liver and kidneys are still functioning well. And I think from my perspective, and that's not because we think the non-steroidals are going to affect the dog's liver and kidneys per se. It's that if the liver and kidneys are suffering another disease because the dog's getting older, then we might want to adjust the non-steroidal dose we have your dog on. It's not because we think the non-steroidals are actually killing your dog's liver and kidneys. It's just because they're processed through the liver and kidneys, and therefore how they are functioning might affect our dosing. So I think it's something that I think it's important that we monitor dogs on non-steroidals. I think it's important we do all those things, but I think it's also important we don't overstate. I've honestly, in the time I've been practicing, I've never seen a dog that has had a problem from non-steroidals that wasn't related to GI upset. I've never seen a dog that I'm convinced the non-steroidals gave this dog renal failure or liver failure, for example. Probably the biggest one that people get super concerned about is the kind of gastrointestinal ulcers associated with giving non-steroidals. And to be honest, if you kind of are monitoring your dog carefully, and if the dog develops vomiting, diarrhea, or anything like that, you stop the non-steroidal. If you give the non-steroidal with food, and if you don't double dose your non-steroidal or make mistakes with dosage, then again, the risk of any ulceration is incredibly low. So it's all about following vet's advice for me, and then not overstating the risks. I think they're low and very conscionable. But that's just my perspective. Anyone?
Yeah. No, I totally agree. I think I love your summary of that, because I would agree. It's my same experience that there's this sort of misconception that the longer the dog is on the non-steroidal, the more the risk goes up. And it's really actually, from an evidence-based standpoint, the exact opposite in terms of efficacy. There's studies that show the longer the dog is on a non-steroidal, the more effective it becomes and less pain that they're in. So I really do try and keep patients on it. One other thing I would point out in terms of the earliest signs of complications would be just the dog going off food, so having a decreased appetite. And so I think some people may confuse that with pain, and that's been the one scenario where I've seen dogs get into trouble, where the clients feel like the dog is in pain and they keep giving the non-steroidal in the face of inappetence, and then have had gastric ulceration and issues there.
I saw one question. I think this is an awesome question, because this will play into what Hannah was using a quote of yours, Kristen, on evidence-based logic. Is what is the role of clinician experience in evidence-based medicine? That's an excellent question.
Yeah. Well, I'm not sure what she quoted me saying, but I think when we look at that pyramid, there is kind of expert opinion as one of those categories on the lowest, kind of one of the low levels of the pyramid. And I think we shouldn't discount our experience, because the longer that we're in practice, we do accumulate our anecdotal evidence. And it's just because there isn't research for every single thing that we do doesn't necessarily mean that we have to discount it all. That being said, I think I'm not sure what my quote was, but I try and practice evidence-guided therapy, where in every chance I get, I'm going to try and base things based on the best available evidence. But the longer I'm in practice, and using the word practice, I've made mistakes and learned from them. And I think that's kind of what research is trying to build upon the things that you've learned. So, yeah. I don't know what you guys think.
No, I think that's super valid. And I think that's something that maybe we don't always fully recognize as well, is that our opinion is very rarely just our opinion. We're a very close-knit community as veterinarians. Most of us have had mentors that we look up to, and so our experience is not just our experience. Our experience is our experience of ours, and then our mentors, and then their mentors. And so you kind of look back and you kind of say, well, I definitely don't think we should discount it. I think we have to follow up and do the studies, and I think those are also important, but definitely not discounting the experience, because it's very rarely just your individual opinion.
That's a great point.
That opinion was formed somehow. So
I think that's where a lot of studies are born, is this theory where we have these opinions and we think that it's been effective. And I said, well, let's look at it scientifically to see how effective it is. So I think a lot of studies, especially in academia, or those that train residents, they always have to have research projects. So a lot of these studies kind of get born in that fact. So it's something that we don't want to discredit, for sure.
Okay. Looking here. More questions. Esme had a question earlier about, given that many treatments that have been comprehensively debunked or considered ineffective in humans, with a list of kind of lots of ones there, but they're still widely advocated in animals, do we think the evidential bar for alternative medicine in animals is lower? And is that good or bad? Someone you want to...
Was it taking a
very
call?
Good question. I don't know. It is a really hard question to answer. I mean, I think obviously we know that animals are not necessarily the same as humans in this respect, and I think there's a big difference here between, and Kristin, maybe this is your area than mine, a lot of it, but in terms of when we say they've been debunked or considered ineffective, I think also if you look at the human medicine, a lot of the time they've not actually been considered ineffective. There's a difference between we think something is ineffective versus we haven't proved it's effective yet because the right studies have not been done. And I think we see if there's something that's been proven in humans to be definitively kind of have adverse effects, then that rarely makes it through to being carried on in the animal world. But if something just hasn't been proven to be effective yet, then that does often make it across. And those are the areas that a lot of time people are working very hard to try and prove that these things work. But as we said, with all the barriers we come up against in terms of cost and time, and is that study rewarded in terms of someone's career, all of those things play a role in whether that ever gets done to the level that is really needed. I guess that would be my take on that.
Yeah, I mean, we kind of talked about the costs associated with doing research, but there's also, research is hard to begin with. And so if you start with a trial that's not well designed, or even if it's well designed and it doesn't go as you had hoped or the manufacturer had hoped, that doesn't necessarily mean that that's the end of that treatment and you just throw it out. Likewise, we'll use lasers, for example. If you have a positive result with one laser using one specific protocol in one study, you can't really translate that to all other lasers. And likewise, if you have a negative study, it doesn't mean that, oh, well, see, their lasers don't work. So there's just still so much research that has to be done. I think on the human side, there's also a lot, at least in the US, I would imagine in the UK as well, that's dictated by insurance. So if certain products or things aren't covered by insurance, then they're less likely to be kind of considered mainstream, and then less likely to be kind of backed by any sort of company that's going to want to do any more research there. So it becomes kind of a vicious circle there as well.
Yeah, I mean, I agree. You know, you can look at one study that shows that something wasn't effective, but then you also look and say the study had 15 dogs, and you know, one could argue, well, if you had 50 dogs, you might have still gotten the same result, or you might have gotten a different result. So, you know, the way I look at it is I don't necessarily, unless something is very just clear, night and day, it's a beautiful study that shows something just does not work or is not effective, I try to keep an open mind, knowing that, okay, maybe in this particular study with this particular circumstance, it wasn't as effective, but that doesn't mean we need to can and throw it to the side. It means that we just need to keep looking. And, you know, one day it may be proven that, yep, it was not effective, or it may be that, no, it is effective. It's just when it's utilized in this way.
Yeah. I think it's Hannah that's on the Canine Arthritis Management. I think so. Said something that a common side effect that people overlook is no effect, and we're treating pain and we need to have an effect. And I think that's something definitely worth kind of discussing. Does one of you guys want to start off with that?
Yeah, I think probably one of the biggest examples, at least in the last few years, is this whole theory on tramadol being used as a pain medication. There was actually a very, very well-designed study that came out of the University of Georgia here in the U.S. That found dogs with osteoarthritis. There were three things used. One was an anti-inflammatory, one was tramadol, one was a placebo. And in the study, using objective outcome measures with washouts, had a pretty clear showing that tramadol was not effective at all for joint pain, whereas the anti-inflammatory was. And so for years, we always said, well, do you think it works? Do you not think it works? What are your thoughts? And we're like, you know, it works on some dogs, doesn't work on some dogs. And I think, you know, some dogs, it may show some pain relief for other things. But a lot of the people that said, oh, yeah, it works great, you know, I think what was happening is it was kind of sedating the dogs a little bit. So they were stoned and having a pretty good trip, but they were probably still painful. And we sort of overlooked that fact of thinking that because they were a little more sedate, or maybe they acted like they felt better, that they weren't still in pain or discomfort. So that's a great question that we need to make sure that what we're using is actually providing an effect, especially when it comes to pain. You know, and that's a big one. You know, if what we're doing is not providing any pain relief, we have no business using it.
Right.
Yeah, I think it brings up the question of how, you know, our outcome measures, how do we know how to evaluate whether or not it's working? And that's a challenge on the research side and in the clinical sense too. And I don't know about you guys, I use a client-specific outcome measure with all of my OA and pain patients, and really trying to identify 2 or 3 things specific to that patient that we are trying to get them to be able to do. And repeating that every 2 to 4 weeks to make sure that we are seeing an effect. We know this from cats that sometimes the effect is actually seen once you take the treatment away. So that I've had that a couple of times with clients where they're not quite sure whether the non-steroidal usually is working, and so we'll say, well, let's try a week or so without it, and then they are like, oh, actually, you know what, there was a big difference when they were on it.
Yeah.
Excellent point. Yeah. And then
I think the BMI that you're mentioning, those clinical metrology, whether it's something that you make up yourself based on not making, kind of come up with yourself based on yours and the owner's kind of expectations, or whether you use one that's already formed. If you're not confident coming up with it yourself, there are several out there that you can use, which will, I find they often can really facilitate your appointment if you're struggling for time, because it'll essentially take a lot of your history for you. So if you're really struggling for time, having a stack of maybe the canine brief pain inventory or the load questionnaire, or whatever your preference is, or there is one for cats as well, for those of you who are feline friendly, is the feline musculoskeletal pain index out of NC State, and you can just have those in your reception, and say every case that comes in that's an orthopedic appointment, just get them to fill it in while they're waiting. And they come in and you've immediately got a lot of your history taken for you, and you know you've asked all those important questions, otherwise you might forget to ask. And you can actually see, like, calculate a percentage, you know, on this treatment, what difference was made when we added in this, what difference was made. But I do think what's important there is at a time, right? Like if you change multiple treatments at once, you never know what's the effect. So if you're going to use those, I would for you to change one thing at a time, take the questionnaire after a reasonable time period, 4 to 6 weeks on that intervention, then add something else, and for another 4 to 6 weeks, then do the questionnaire again, and then you can really tell what's working and what's not working with a bit less subjectivity.
Yeah, absolutely. Here's one that I think was just posted. So do you, oh, there it is on the screen. Do you work with less evidence theories, and can you give examples on how you personally justify it and do it safely?
I guess I get the one that I use most, that probably does not have a lot of evidence behind it, or really, to be honest, next to no evidence behind it, will be the gabapentin and amantadine. So the additional analgesics that I use when I've tried a non-steroidal, and a non-steroidal in and of itself was not enough. I do try and be evidence-based about it. So I try and go with amantadine first, but that's really based on one study, one fairly small study, and from 1997, I think it is. So it's old too. But it is done by an absolute guru in osteoarthritis, Duncan. So I'm going to believe it. but yeah, so I tend to go with amantadine first, just because there's one study out there that supports what I'm doing. And then if that doesn't work, then I'll add in gabapentin, which, if I'm honest, if I look at the literature today, there's not really anything that convinces me that it's effective for osteoarthritis, other than, as we spoke about, my personal experience and the personal experience of owners with dogs that I've treated. So I'm right down at that bottom of the pyramid of evidence with using that. How I justify it, because the risk of side effects associated with either of them is so low. And when they do have side effects, they're completely reversible by stopping the medication. So with no long-term effect. So as long as we're monitoring that patient appropriately, I don't have a huge problem with doing it. But I do have in the back of my mind every time that slight guilt that I don't have the evidence behind it. And I also haven't done anything about it in terms of trying to do a study to prove that either one of them work. I use them daily, probably, and yet I haven't made the effort to do that study. So I feel guilty, but I do it.
Yeah, I agree. I mean, I like amantadine and use it. The same thing with gabapentin. You know, the way I try to justify it is the it's relatively safe. And in my mind, if we're thinking about chronic pain and this concept of central sensitization, which means you kind of get this wind up pain, so you're feeling more pain than what should be there, and that we've got capsular distension and engagement of nerve fibers. Maybe there's some help on the neuropathic side of things. What I would love to see somebody do is the demographic study, because I'm willing to bet in the world the usage of tramadol went down about the same occurrence as the usage of gabapentin went up. Because we were like, well, they told us the tramadol is no good, and we're like, all right, well, let's use gabapentin because we don't have a lot else to choose from. So.
Yeah, so I would absolutely agree with both you guys on amantadine and gabapentin. I have nothing else to add there. But in our rehab center, I think we do a lot of things that still have a lot left to learn about. Really, just the basics, and what I believe that the foundation of rehab is just land-based therapeutic exercise. And we have very, very, very little research at this point to show that does anything in dogs with OA, where on the human side, exercise therapy has very well been shown to be an important part of OA management. So exercise therapy, even underwater treadmill hydrotherapy, a lot left to learn there. And then, of course, the things like laser, pulse electromagnetic field, shockwave therapy, intra-articular injection. So I do all of those things. And how do I justify them? For me, absolutely, it's safety first. So of all of those modalities, most likely to have a safety issue would be laser. If you have a high intensity laser, high power laser. So in our practice, we don't have heat generating lasers. The two lasers that we use aren't going to burn any tissue. So first and foremost, the technicians have to know how to use them and know what they're treating and use that safely. But yeah, we still need more research in all of those modalities.
What about supplements? Hannah asked that CAM followers, and I'm sure care followers, and Kristen, you can talk about that, always want to know about supplements. So can we do a quick summary how owners can purchase supplements safely? As a lot of owners come online to find interventions they can do outside of vet care.
Yeah, I mean, absolutely right that everybody That's the first question that the clients want. And so for me, again, coming back to the do no harm and safely using them, until we have great evidence to show that one particular product is better than the other, or all of them are working, my personal opinion is to go with products that have quality control and at least have in the US we have the NASC like kind of seal of approval. So there is some sort of quality control that goes into it. Usually, or many times, those are products that are sold by the veterinarian. So I like that relationship. So rather than clients just going to the local pet store and buying something that doesn't have any background to it, I feel much more comfortable with clients purchasing something that we recommend, whether we carry it in here or we're specifically recommending it. That's my approach.
Right.
Yeah, I mean, for me, after we've had that discussion with clients about, safe, efficacy, maybe not. But when I lecture to veterinarians, one of the things I say is, if you tell an owner your dog needs to be on a joint supplement, well, what are they going to do? They're going to get in the car, they're going to pull up on their phone, and they're going to find, okay, there's 52,000 choices. I'm going to find the cheapest one because they all say the same thing. And, at least in the United States, there's no federal regulation. So that means the three of us could get together in our garage, put whatever we want in a capsule, slap whatever we want on a label. We can make some side money if we wanted to. So when we recommend a product, we want it to be something that has been tested, that not only the quality, but also the safety. We want it produced under good manufacturing protocols. So that way, if we're giving something that could be effective, we want to at least get, the owners know that what's in that tablet is what's on the label, and it's been manufactured appropriately and not done kind of on the side and kind of somebody's backyard.
Right. Yeah, I think I'm very much on track with both of you guys there. In terms of, I think there was a study that was done, I think, correct me if I'm wrong, guys, I think it was in the 90s. So it was a little while ago, but they did a study in the late 90s, I believe, where they looked at, and if you go and just buy something off the shelf that says it has glucosamine and chondroitin in it, how much glucosamine and chondroitin does it actually have in it? And it varied dramatically in terms of, like, if it didn't have any control over it, you really didn't know what you were buying. It's kind of like buying drugs on the street. You actually have no idea what's in the thing you've just bought. So I would definitely say there is
93%.
Exactly, there's evidence that what is on the label is not what's in the product itself. So definitely get something that's veterinary recommended. Even if you don't buy it from them directly, you can get a recommendation and then buy it online wherever you can find that product cheapest. That's absolutely cool, and I would totally do that. I'd go looking for the cheapest way of getting that product, but I'd get the product recommended.
Yeah, absolutely. So CARE, I probably should have included that when I introduced myself. So CARE is Canine Arthritis Resources and Education. It's a website that I created about a year ago, caninearthritis.org. So somewhat of the US version of CAM. And I created CARE to be a practical, evidence-based resource for veterinarians and for pet owners caring for dogs with OA. So that's CARE.
Okay. I don't know, Hannah, do you want to feel free to kick me off if you want to come and close this out? I won't be offended. You need to kick me off to come and close.
Me neither. I've got to get back into the operating room here soon.
I've still got another half an hour I was planning on being here. So.
Oh, yeah. Well, hey, there you go. You can hang out.
10 top tips. Oh, we're going to take this in turns. 10 top tips for evidence-based medicine. Oof.
Oh, I'm not starting.
Off the cuff, yeah. Well, I'd say number one, trust your vet.
Yeah. Yeah, and I think probably the next one I would say is the levels. Like, although there is that pyramid, and I have a huge amount of respect for that pyramid, like, I don't think we should really be discounting any side of that pyramid. So owner experience, veterinary experience, all of those things do play a role. And when we talk about evidence-based medicine, I hope we're all I think we are all taking all of that into consideration. So owners should I hope owners are aware that we are taking all of that into consideration. We don't just read a study and discount what you tell us that your dog's having a positive response.
Yeah. And I think, don't take your Aunt Susie's Facebook post as being the gospel for avoiding your veterinarian's recommendation. I think all of us, if you've come across something that you thought, oh, well, I read this and so said they thought it worked, ask your vet about it. Don't just neglect to talk to them about it, because that's what we're here for. Because we can tell you, I don't have a clue what you're talking about. I don't know if it's going to work or not. Or we can say, yeah, that may be helpful. And because every pet's different. So what works with one pet, they may have a different set of circumstances as to why they're using that modality versus your pet. So, always discuss those things with your veterinarian to try to get as much evidence and as much information as possible.
Yeah.
Next tip, I guess, OA and evidence, it would be, again, don't overfeed. Don't let your animal get overweight. And if they are, work with your veterinarian on a weight loss plan.
Yeah. And I think
for me, it's daily exercise.
Yeah, absolutely. And I think something that sometimes it's very easy to take it in a negative way if your vet says there's no evidence behind it, so I can't recommend that. And I think just taking that with the best of intentions and presume best intentions, because the reason that we're not suggesting it is because the evidence isn't there yet. But we're probably all waiting for it just as anxiously as you are. So just maybe give us some time, and hopefully that evidence will be there. And next time you talk to us, maybe we'll be able to recommend it. But if we're not recommending it, it's with best intentions, not because of any other ulterior agenda that may be presumed.
And the one thing that is not going to cost you any money, and your veterinarian is not going to financially benefit at all from, is taking your dog out and get them walking, get them moving. And that goes side with what Kristen was saying about getting weight off of them. All it takes is a little bit of time dedication on your part to walk your dog. It doesn't cost you anything, unless you don't want to walk your dog and you pay somebody to do it. That's another story. But get the joints moving. Yep.
Another one that is unlikely to have much research, if ever, is going to be what Hannah always talks about, is the home environment and rugs and non-slick floors. And, we don't, as far as I know, we don't have any research to support that necessarily, especially in the older dog with OA, but I can't tell you how important that is, making sure that the dogs have a good grippy surface inside their home, and especially if they have to do stairs.
Yeah, I think the quick in-home study you can do is like I said earlier when we talked about this before you jumped on, is go ahead and get your bathroom floor really nice and wet. Slide on it without shoes on, and then when you fall and slip, see if it hurts.
Yeah.
And if it does, then you can be assured that if your dog's slipping and sliding on the floor, it probably hurts.
Yep.
Okay.
Did we get to 10?
I don't know.
I'm gonna say yeah.
We're gonna round up.
I think that means Hannah's coming back.
Yeah.
Oh, just me. There we go.
Thanks, guys. I look really orange. I look like an Oompa Loompa. What happened? The light changed here. I'm going to say a massive, massive thank you to David. I did say goodbye, David, but sadly, Be Live doesn't let 4 of us on at the same time, which is just like so frustrating. But thank you, guys. Karen, if you do need to go, then that's absolutely fine. If Kristin's still got 20 minutes, we can answer some questions. I don't know where you are, if you've still got quite a lot to do.
For me, I could probably stick on for another 10 minutes or so if you need.
Okay, cool. David, thank you so much for your time. I know that you've got to go back to surgery, so he's a legend. And Kristin, great to see you. Sorry about your sudden arrival. By the way, you're live.
Thanks.
Sorry.
Yeah, I'm sorry about that.
No, don't worry about it. So basically, I hope that everybody that's watching realize that vets are really human, and I really wanted this Facebook Live to come across that we care and we really put a lot of thought into the decisions that we make. And it frustrates me quite a lot when people assume that we choose interventions that benefit us, and that really did frustrate me a lot in recent months. And I wanted you to realize that there's a lot of work that goes behind why we make the decisions that we do. So just to leave that out there. 10 top tips, kind of, guys. I kind of left you a little bit there, didn't I? Not OA evidence-based. Let's do OA in general. So one of the things that's really important to me about CAM is that anyone of any price bracket can come and get advice from us. And that was really brought home to me many years ago when I went to someone's home, and it was a little old lady, and she was obviously on a pension, and she spent all of her money on supplements that she had bought from the local pet store. And you know the ones, they've got amazing statements on them, and you sit there just going. And she'd actually chosen that over seeing her vet. She decided to spend her pension on a load of supplements from the pet shop rather than actually seeking advice from her local vet centre. And that kind of broke my heart a little bit, because it really said something about what the public were thinking about what we were doing. And you'll be pleased to know it was a happy ending. The lady did get the attention that she needed. We put rugs down. We got weight off the dog. We stopped the dog jumping off the sofa onto a laminate floor. We got it on a non-steroidal. And actually the dog really, really improved. So please don't be scared of your vets. We're all human. And we're here at this time, day or night, giving up our time for free. So please be nice to your vets. We've had some lovely, lovely comments here about what people feel about their vets. So that's awesome. You've got the platform, guys. Is there anything else that you would like to mention whilst you're here? You know, we're quite lucky that these get circulated again. We get 5,000 views. So is there anything that you're absolutely desperate to shout about before we answer the last few questions?
I would say a couple more tips, just working in the therapeutic exercises into a walk. So as David mentioned, just taking your dog for a walk, but I often like to have clients, every time they come to a stop walk or any opportunity to have the dog sit and then stand, and then you get some active range of motion and some strengthening exercises there. And then as soon as they get home, do some active stretching. So if they have stairs, the front feet go up a little bit higher, the back feet are a little lower. If you sit kind of where the dog's front feet are, give them some love up front, and then it's stretching out their hips. So keeping the joints nice and limber and the muscles stretched out. No cost associated with that. The dogs love it, and it goes along with the exercise part. Yeah,
you'll laugh. Do you use one of those online exercise programs that we use, canineexercise.com? Don't mean to plug them, but I do. And I did exactly that the other day, and I kind of made this like little storybook of what I wanted them to do on their journey. And 3 minutes after walking, you're going to do this, and then 2 minutes you're going to do this. And it was like, follow the road, follow the road. But people are actually going to do it, because if you said to me, Hannah, find 20 minutes a day to sit down with Luna and the kitchen where the rug is, do this exercise, boom, 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 boom. I just don't have that life. I totally agree with you. Yeah. We've got a corker of a question, and it's from the Lindsay Tyndall, and it actually comes from the CAM forum. Can you ask regarding non-steroidals and whether they might damage the joint? So this all goes back to when there was an in vitro study with, I think it was meloxicam, and its effect on chondrocytes, and it gave non-steroidals a really bad press for quite a while. It's quite an old paper. Like, do you have any thoughts on that? Because it was, as I say, a recent question.
So my perspective on that is that was a benchtop study, right? I don't think that was actually a kind of in animals study, if I remember rightly, in terms of, I think, So I think there's been a lot of studies like that, kind of if you spray meloxicam at a chondrocyte, what does it do? And if you spray bupivacaine at a chondrocyte directly, what does it do? And yeah, chondrocytes don't like much being sprayed at them. They're pretty fragile. So it's I think we have to put that into context. And I think from my perspective, in an actual dog that's receiving a comprehensive OA plan, the only way I can perceive that a non-steroidal will cause joint damage is if it's done where you basically relieve the animal's pain and don't also look at what they're exercising. So if you relieve their pain and then let them over-exercise their arthritic joint because they're now not painful, not that I'm saying we should keep them painful so they don't exercise. I'm not saying the converse is true, but if we just analgese them and don't look after them, let them run around, let them play ball, let them chase sticks, let them do all those kind of things, then yes, the chondrocytes are going to suffer. But I think if you're just using meloxicam at an appropriate dose, as advised by your vet, I don't think there's any really like hard evidence that's going to say that meloxicam is going to damage the chondrocytes within the joint. It doesn't really get to the joint as meloxicam itself anyway. So I would say not something to be concerned about unless you're not doing a tailored management plan and considering the whole dog.
What do you think,
Yeah.
Kristin? You saying?
I would totally agree, and I would say, you know, there's an opportunity to do just the opposite, because we know that I think David talked about the flares of arthritis, but the more and more we learn about the pathophysiology, or just kind of what's happening, the synovium, which is kind of the membrane that surrounds the joint, and that's where the nerve endings are, and there's a lot of blood vessels, and that's essentially where inflammation happens. And that inflammation creates a cycle of degeneration and destruction of the cartilage. So the more inflammation we have, the more destruction of cartilage and the consequences there. So if we can tamp down that inflammation using a non-steroidal, then there's maybe the opportunity to slow down the whole progression of the disease, maybe. So I consider them to be much more helpful for the joint environment than detrimental. But definitely to your point, if there's too much activity, there could be too much forces in the joint.
Yeah. I think that's where this word, the multimodal approach, it's not a choice, it's a must, isn't it? And when I do feel sorry for first opinion vets, because quite often we're restricted on time, where we're bombarding all this information at the owner, and they might cherry pick, or they might just only listen to what they wanted. Anyway, the point is that if you're going to introduce a management plan, you have got to tick all the boxes. So yes, can you just explain to owners, because I think there's a lot of misunderstanding about trials, the difference between in the body, in the zone, in the environment that we're wanting it to work, and actually in an agar upload. And a lot of papers that they see under different companies that are promoting something online, there's always loads of references. And whether they actually lead anywhere, whether the papers actually even exist, or whether they actually are valid, or if they were done in the 1990s and since, or they're back to the 1960s, there's still something that people overlook, isn't it? And can you just explain that, Kristin? Because I think people need to understand that.
Sure. So, you know, I think when if you're looking at a supplement or a drug, often the first step in a trial is to do what's called an in vitro trial. So that is whether it's a chondrocyte or a type of cell that's part of the joint, or, you know, something in a petri dish with the supplement added to it. And it's a very, very, very controlled environment. And it's a really nice way to do research, because you get to control every last bit of it, and you don't have opportunities, or the same degree of opportunities for confounding factors or external things. So that's usually the baseline of where research is going to start. And then it moves on to typically in vivo, or in an animal, in a live being. And many times, especially if it's human research, they'll go to a rodent model, so rats or rabbits or mice, and kind of do a similar experiment, whether it's creating inflammation in a joint or creating global inflammation, and then giving a product, or giving part of a product, and then seeing what the results are. And that's still very controlled, because if you're using, you know, unfortunately, if you're using lab animals, they're all very, very similar, and you're controlling everything they eat and everything that they do every day. And so the outcomes in the research results you're going to get tend to be a little bit cleaner than when you go the next step and you say, all right, now I'm going to try this same product in the clinical dog or in the clinical human, in the actual environment that they live in. It's a much better study in terms of real life and realistic, but there's all these other potential external factors that can change, you know, the potential for results. What the dog owner does with the dog every single day, what they feed, what treats they get, there's a lot more variation. Does that answer? Does that kind of get what you're?
Yeah, no, it totally does. Yeah, it totally does. And I think it's something that people just overlook. And I know I'm blessed with the gullible gene, which up until recently I was a problem, but now I realise it's really helpful, because I get to see it from other people's perspective. I only just managed to get into uni. So I kind of see something, and you see all of the small print, and you're like, wow, this must have so much evidence behind it. Look, and it looks clean, and the website's clean, and you know they sound really clinical, and they sound like they know what they're doing. And it's very easy to kind of get dragged along with it. But something I guess I'd quite like to say is, you know, if your vet's not stocking it, you know, just have a little bit of suspicion there. You know, if it's not something that we widely use, is it as effective as they're making it out? And soon as something goes into print, everybody believes it's gospel. So as soon as there's a website about it, and as soon as it's got some kind of, you know, evidence. So just be savvy, guys, you know, and your vet's not a bad person. So actually, that's got really weak evidence behind it. And I'd rather we did something a bit more Main Street, and then we can look at adding that. You guys, oh my, Lindsay's. Yeah, my favorite is that bleach kills cancer cells in the picture. Oh, let's put that one away. So, anyway, have you got any more questions before we call it a day? Because I think it's been an amazing live. I'm sorry that Be Live didn't let us all four come into play, but to be honest, I put the best on stage, and I'm really grateful for you giving up your time to make this happen. Kristin, just tell them a little bit more about CARE, because I know that there's a lot of stuff on your platform that we don't cover as well as you do. So give them I'll put their email address, but website address, but also just tell them how they can find it and what sort of content they can get there.
Yeah, so again, caninearthritis.org, caninearthritis.org. And there's a section for dog owners, and then there's a section for veterinary professionals. And it's a lot of the same content, just, you know, the veterinary professional side is written to in a little bit more scientific manner. But we have a lot of information on there about some of my favorite parts that I use with my clients all the time are a long list of nutritious treats and kind of some ideas of how to make sure that you're not overfeeding your dog and what treats are okay. From what we really wanted to do is build the relationship between the veterinarian and the pet owner. And so there are some things that the veterinarians get access to, such as lots of videos on different exercises to do with dogs, how to do an ice pack, how to do passive range of motion. And that's, you know, then the veterinarian can send that to their client if they're recommending it. But we still do have a lot of articles. So we have a great one from you guys from CAM about, you know, the impact of playing ball. Yep. So I share that with my own clients all the time, and I think it's really eye-opening for them. So yeah, we're trying to cover the whole multimodal aspect. We have a comprehensive care quad, which is kind of my approach to it, but also a lot of helping. I know this is a huge part of what CAM does, is just the recognition of what OA is and what pain looks like. And so there's some tools in there to help clients identify pain in their patients or in their dogs as well.
Yeah, definitely. I think a take-home little piece of homework for anybody that's following, anybody that listens to this at any point, is please tell everybody you know that has a dog or a cat they don't have to cry to be in pain. I generally, that happened to me twice a day, where an owner will come in and the dog will be toe touching, lame, and say it's okay, but he's not in pain because he didn't cry. And I'm like, yeah. I generally say, have I got backache? Yes, I have. I'm not crying. You know, you get on with life. And it's kind of those things that owners suddenly go, oh yeah, obviously. So as long as you say it in kind of quite a light-hearted way, but tell your friends, because if we can pick up the signs of pain earlier, we're going to have a lot better results for longer, is the basic take-home message, isn't it?
Yeah. I think the other thing that I find, just real quick, is that when I think people are scared of the diagnosis of arthritis. So sometimes they have blinders, they don't want to talk about it because they feel like it's a death sentence, and it's not. And just like you said, the earlier we can identify it and start a treatment plan, these dogs can live really long, healthy, active lives. So just having hope and not being in despair if it is the diagnosis that you come away with. Yeah,
the lovely Lindsay Tyndall, who I call Lydia and Yellow Knickers, I'm embarrassing her online because I love doing it. She's got a lovely phrase. She says, arthritis is not the end of the road, it's just the start of a new direction. And that really, really is what it is. If we catch it early enough, we can actually say, okay, we might need some anti-inflammatories now. We're going to get everything under control. We're going to get the right weight, the right lifestyle. And we're going to potentially come off of these. And you're just going to have a slightly different life with your dog, but it's still going to be amazing. So that's the need to spread your dog more years is what we're trying to tell people. Because personally, as a vet, I'm fed up of putting dogs to sleep that don't need to be put to sleep, you know, too soon, and they've gone through too much getting to that point. So let's spread the word. Thanks, guys. I'm so grateful. You did amazingly well. The time delay messages were like perfect. So thank you. Thank you, Karen. So great to see you. And Kristin, always a pleasure. And hopefully we will see you guys again soon.
Yeah. Yep. Okay.
Right.
Bye.